Hi everyone. This presentation was delivered at the annual conference of the British Association of Social Workers in June 2024. It was put together by myself and Anne Cullen, who is the research lead for the Association of Palliative Care Social Workers, which sponsors the trauma-informed palliative care project. The theme of the conference was sustainable social work. So we hope to show the way that trauma-informed palliative care aligns with the concept of sustainable social work. We'll start with a vision of palliative care and the way that access to palliative care services is not equal, and the links between that inequality and whether people have experienced trauma. We'll look at what's being done in general and what we can do as social workers in particular. And then as part of that, look at how we need to reconsider the concept of well-being. We'll also look at how the eco-social work model fits with the ideals of trauma-informed palliative care. And I'll tell you a bit about the trauma-informed palliative care project. So the vision behind eco-social work is consistent with Cicely Saunders' vision for palliative care. When she was a social worker, she saw how doctors would despair and give up on terminal cancer patients when they couldn't cure them. And often people were left inside wards, perhaps in pain and distress. And Saunders recognized that physical care is only one dimension of a concept that she developed, which she called total pain, which includes the physical but also psychological, emotional, social, and spiritual distress. So those are the 4 dimensions of holistic palliative care. But eco-social work adds an ecological dimension because it considers all beings as interdependent and it sees our connection to the natural world. The Trauma-Informed Palliative Care Project is one example of a social work-inspired project that works in a way that is aligned with the eco-social work model. That model was developed by Heather Boetto, who says that to be sustainable, we need radical whole systems change in social work practice, in society as a whole, and in our understanding of well-being. So hospice and palliative care clearly is hugely beneficial to a lot of people. But it's clear that people who are marginalised and systematically disadvantaged may not access or derive as much benefit. And these are often people who have experienced trauma. They may not get referred for palliative care in the first place, but even if they are, they may be unable to engage in the way that the system is put together, make appointments at set times and so on, and then they may be discharged from the list. And even if they can come in there and use the services up to a point, there is still a risk of re-traumatisation. In addition, it's clear that staff are at risk of vicarious traumatisation, burnout, and compassion fatigue. I'm sure you all know what trauma is, but just to have said it in the context of this presentation. So this is one of the original definitions by the Substance Abuse and Mental Health Services Administration in the US. They define trauma as resulting from an event or series of events or set of circumstances that is experienced by an individual as physically or emotionally harmful or life-threatening, and that has lasting adverse effects on the individual's functioning and on their mental, physical, social, emotional, or spiritual well-being. Stephanie Dallam adds to this a definition of re-traumatisation in healthcare, which she says is a process in which evocative events in healthcare replicate stimuli or dynamics associated with childhood trauma, causing survivors to be overwhelmed by post-traumatic stress symptoms related to the original trauma. So trauma often results from adverse childhood experiences, but obviously can also occur later in life. And it changes the way our brain and endocrine system work. That affects the way we experience ourselves in the world and our stress response system, which then means that we avoid circumstances that remind us of the earlier trauma, or that we get triggered by reminders of the trauma if we can't avoid them. And that is what makes it harder to use medical treatment and palliative care services. The more adverse childhood experiences somebody has, the more likely they are to live with multiple disadvantage, which then in itself creates further risks and barriers to access to services. And multiple disadvantage, as you know, is 2 or more life challenges such as mental health issues, homelessness, offending, and substance dependence. Barbara Gansel in 2016 wrote a paper in which she highlighted the high incidence of trauma in the population in general, but she said it's more prevalent in older populations and those using palliative care services. And of course, that can impact on the likelihood of experiencing a good death. So Stephanie Dallam developed what she called the healthcare re-traumatisation model. She says events in healthcare which remind us of earlier trauma pose a risk of re-traumatisation. And when she did this large meta-study that she did, she thought that there wasn't enough guidance for practitioners on how to work with this. So she developed a conceptual model to guide practice. She identified a cyclical process. So when people who are already hypersensitive to threats engage with medical services, they become exposed to triggers, and that creates a post-traumatic stress reaction, which then in turn leads to avoidant coping behavior and non-compliance and so on, not turning up for appointments, but also to behavior which can be interpreted as challenging. And we can intervene in this cycle by recognizing people's safety needs and supporting a change in coping strategy from what she called avoidant coping to proactive behaviors. And that means that we help people identify what the triggers are and then both try to avoid those triggers by doing things differently, but also support them in coping so that they don't become triggered by what happens. David Feldman developed this approach specifically for palliative care services, and he called it the stepwise psychosocial palliative care model. He and other people say that we need a universal precautions approach because people may not know about their trauma until they're triggered, and also, even if they do, they may not be ready to share it. So we have to relate to everyone in a way that assumes trauma and ask what would help them make it safer and easier for them to use the services and then adapt the services accordingly. So there are 3 stages to his model, and you only move on to the next stage if trauma symptoms haven't been resolved, and that also depends on a person's time that they have left, their stamina, and their willingness to go ahead. So the first stage is to intervene to alleviate distress by taking actions on behalf of the client. And that's a bit counterintuitive for us as social workers because we tend to try and empower people to do things for themselves. But patients who are near the end of life or seriously ill, they just don't have time or energy to take the action themselves. The second stage, if that hasn't resolved the trauma symptoms, is to normalize their symptoms and to offer them tools to use on their own to cope with distress as it arises. So it's a form of psychoeducation and coping support. The third stage is, and you only go on to the third stage once you've assessed the effectiveness of the previous interventions and you've checked to see whether the person actually has a diagnosable post-traumatic stress disorder, and you have to assess the patient's energy, prognosis, ability, and willingness to continue. And actually, whether it's diagnosable or not, there's a whole debate around that as well, because there is a sub clinical presentation that's still very impactful for the patient. So it may be that you need to offer these further measures even to people who can't be diagnosed as having formally as having post-traumatic stress disorder. But then the third, depending on the person's energy, prognosis, ability and willingness to continue, the third stage is trauma-specific treatment for full threshold post-traumatic stress disorder. Because that involves thinking and talking about trauma memories, you're less likely to do that with hospice patients because of their limited prognosis. So the core principles of trauma-informed care are safety, trustworthiness and transparency, peer support, collaboration and mutuality, empowerment, and cultural and historical gender issues. So looking at the UK and where we've got to, it seems that Scotland is light years ahead of the rest of us. They already have a trauma-informed policy for all public services, and they commissioned a 2-year piece of research to reduce barriers to access and prevent re-traumatisation. So from depth interviews and qualitative data analysis, they identified some best practice principles and wrote up a report which offers questions for consideration to help organizations become more trauma-informed around 5 principles and across 10 implementation domains. They've also developed a toolkit and training to develop a trauma-informed workforce. So in the rest of the UK, trauma-informed care or practice is developing in a wide range of services, like mental health and children and families, probation, and so on. But as far as we know, little specific research has been done into trauma-informed working in hospice and palliative care. So it's very exciting that Rebecca Salama has started a PhD scoping study last year to look at what is known and to set directions. So that was funded by Lancaster University and initiated by the Trauma Informed Palliative Care Project. Hospice UK had already done an excellent report on equality in hospice and end-of-life care, and is currently doing a series of deep dive studies into specific areas of disadvantage. Also, we know of different hospices and palliative care services that are trying out different ways of applying aspects of trauma-informed working. So there are good initiatives, but trauma-informed practice is not systematically adopted in hospices so far. What has increased is the use of trauma-specific therapies like EMDR and mindfulness. And there are some very interesting new therapeutic approaches, like those connecting with the restorative power of the natural world. For instance, Michael Kearney's work on deep listening to patients, staff burnout, and palliative care for the world, and use of psychedelics at end of life. So what can we do as social workers? We notice that we're often overstretched, demoralized, and isolated, and I'm sure that's true of other professions just as much. And that makes it hard to see beyond the immediate demands of our work environment. It's hard to engage with wider networking, learning, and social action. We're often stuck in hierarchies of power and relative professional status and restrictive systems of care, and services can be commodified and procedure-driven. We're also taught to keep our personal and professional selves separate, and that makes it hard to allow ourselves to be vulnerable, to listen deeply to ourselves as well as our clients, and it makes it hard to reflect on our own trauma triggers. So far, it seems nobody has brought people together to develop or promote the idea of trauma-informed palliative care, what's been called there's no merchant of meanings, and we hope that the trauma project is starting to fill that function. So just a little bit about the emergence of sustainable social work. In the 70s and 80s, there was an integration of ecology and general systems theory into social work. And then in the 80s and onward, there was more of a critical look at how we use power, who benefits from the rules of the game. And that revealed two positions. One of weak sustainable development, which is a still neoliberal market-orientated development, which says that we can grow and maintain commodity production without using natural capital because we can make gains in efficiency. On the other hand, the other end of the spectrum, if you like, there is the model of strong sustainable development, which is based on the idea that there are real limits to growth. We can't keep developing our productivity and growth. We need a decline in commodity production, and we need to conserve and restore natural capital. By 2015, the Global Agenda for Social Work and Social Development promoted the environmental and community sustainability as a central aim. And the UN 2030 Agenda for Sustainable Development has given us the Sustainable Development Goals, which are founded on human rights and ecological. So Heather Boetto developed what she called the eco-social work model. She says the natural world is one large system of relationships. And so we need a complete paradigm shift to a holistic perspective and whole systems change. We need an integrated view of environmental, economic, and social dimensions. And we need a move from an individualist and anthropocentric perspective to an ecocentric one, which means that the natural environment is the central concern, not humans. And social problems are understood as being ecosocial in nature. We have to face and accept the darker qualities of life, like disease, natural disasters, and death. We can't be in denial of that anymore. And we need a new social agreement based on human rights, empowerment, and ecological justice. That means breaking away from modernism, neoliberalism, consumerism, and industrial capitalism, and free market strategies. And that involves a process of deep social learning. So that means that social work has a central role, but it needs to be transformational. And also, this is not denying the importance of other professionals, of course. This was delivered for a social work audience. So the point made by Heather Boetto is that social work needs to be transformational, but it's embedded in the welfare state. And it's become a domesticated profession. There is a real pressure for the social worker to become or be an agent of the state. The profession relies on the conventional, positivist, modernist paradigm. It's often bureaucratic in many respects, managerial and policy-driven. And as it stands, the rules of the game sustain modernism and neoliberalism. In a way, we help people adapt to a damaging status quo. Working for structural and political change, she says, is deeply political. So the problem is we're rooted in the system. Boetto says that the core problem for the social work profession is that its modernist roots contradict the aims of its practice. How we work should be based on what we think and believe about people in the world, but at the moment those things are not aligned. Social work needs to become congruent across its ontological base, which is our sense of self and belief system, and its thinking, its epistemology, and its practice, the methodology. So to become more congruent, we need to expand the role of social work and change the focus of intervention. We need to work with people as embedded in their environment, and I think this is true again for other professions just as much. And that means challenging the focus on individual casework. We have to intervene on all levels: personal, individual, group, organization, and structurally and politically. We need to be more authentic, aligning our personal and professional selves. And we need to develop spaces to discuss new perspectives, to build networks, communities of practice, and to foster resilience and social capital. We need to challenge structural inequalities by working in emancipatory ways and promoting social action. We need to be aware of how we use our power and the tension between doing good versus being an agent of control. We need to promote co-produced participatory research and celebrate diversity, the intrinsic value of human beings and of all life forms. And we need to balance individualist and community values with the wider collective good, almost, looking at a global perspective. We need to change our understanding of well-being to a relational understanding that is environmentally sustainable, which means that we look at more than a material element. We need to include considerations of spiritual, communal, and collective dimensions. So Helner and Hirvelami have developed a relational concept of well-being that I won't go into in depth here. I mean, this gives the reference, and you can follow it up if you're interested, just because otherwise it'll. I do want to quickly look at how the ideals of eco-social work and trauma-informed palliative care align. So trauma-informed palliative care also makes well-being central. It focuses on healing rather than cure. It sees illness and death as an intrinsic part of life and an opportunity for personal and relational growth, quality of life, and a good death. Its bio-psychosocial spiritual model is holistic, relational, and needs-based, and it stresses the non-material, non-physical aspects of well-being, which makes it easy to integrate with the eco-social approach. It sees palliative and end-of-life care as a social ecosystem within the welfare state. And that ecosystem is central in considering how to support individuals within it, including staff and carers. It aims at whole system change. So trauma-informed palliative care is committed to equality and social justice, and it aims to ensure equal access to the services for marginalised communities and to be empowering. It wants to build non-hierarchical relationships of trust and collaboration. And it uses a trauma-informed universal precautions approach. To make work in the palliative care ecosystem more sustainable, it says we have to improve support to the workforce. And it sees the parallels between caring for the environment and caring for oneself and the community in a way that Michael Kearney has developed. The eco-social work model explains obstacles to change, which it brings back to the modernist welfare state. And it can guide us strategically on how to develop trauma-informed palliative care. It can indicate areas and methods for research, and it can inspire and motivate us. So just to tell you a bit about the Trauma-Informed Palliative Care project, we started in 2022 to address what we'd seen. which was the exclusion and inequality of access to palliative care services, the risks of re-traumatisation, and the risks of vicarious trauma, burnout, and compassion fatigue for staff. It aims to develop a community of practice, to promote formal research into best trauma-informed practice, and to promote self-care. We need to acknowledge our own fears of illness and dying and vicarious and secondary trauma through, for instance, reflective practice, peer support, Schwartz rounds, and mindfulness. We also, in the longer term, hope to develop educational opportunities and materials. So we've had an overwhelmingly positive response, but of course it's very hard to change practice. So that's going to take a while. So we've already started the community of practice. And when I put these slides together, we had over 350 people who have come together within a year. We've already got 393. So people are joining all the time. We're an informal network of people of different professions and services in the UK, but across the world, quite a lot of people from the US and Australia, Canada, Africa, Eastern Europe, all over. And we want to share knowledge, expertise, experience, and resources. We're all just learning together, and the community is evolving all the time. We've started a communications platform, which is one of the Mighty Networks platforms, and it's called Trauma Informed Care. It's totally free to join. So you're very welcome to click on the link or cut and paste it into your browser. Once you register, you will get notifications of events and by us, but also sometimes by other people that might be of interest. And you can regulate how often you're notified. So you're not going to, you won't be flooded by emails. We try and keep our emails to a minimum. So you can enter your profile, you can start discussion groups, you can direct message other members, you can post on special interests or upload articles you think are interesting or favorite books. And researchers can use the platform as a resource for collaboration or access to research subjects. We hold quarterly community of practice meetings, which have short presentations by members or invited speakers on, for instance, case studies, aspects of theory or practice, or dilemmas that people have encountered. And then we can have small and large group discussion. And we also do quarterly webinars, presentation on a range of topics and with time for questions and discussion. We are at the moment reviewing this, and we might be, we've got so many good people that we want to get out there that we might increase the frequency of these meetings and have ad hoc in between meetings. All presentations are recorded and uploaded onto the platform, and we hope to offer training in the future. We also promote research, and again, I'm not going to go into this slide just for the sake of time. I won't go into this in depth, but just to say that a couple of doctorate in psychology courses are happy to put our research questions to trainees as possible projects for them. And we are in touch with some potential research sites, but where we're stuck is we don't have any field supervisors. So we can't go ahead with this. So if you know of anyone who would like to be a supervisor, please ask them to get in touch. So to conclude, the move to trauma-informed working in palliative aligned with the emergence of eco-social work. Eco-social work updates and extends Cicely Saunders' vision of holistic end-of-life care because it considers all dimensions of human being in the world: physical, psychological, social, spiritual, and ecological. The key aspects of both eco-social work and trauma-informed practice in palliative care include that we need to develop a new understanding of well-being and quality of life. We need to support people to feel valued, connected, and with a wider sense of purpose, meaning, and hope. And we need to recognize the need to align our ways of being, thinking, and doing. Both stress the need for radical whole systems change to achieve that. So that's the end of this presentation. There's the link again if you want to join our platform, and I very much hope that you do. You'd be very welcome, and we want your views and your ideas about how we can develop our community and improve the platform and so on. And I'll just flick through some references so that you can follow up if you want. So here are some more to do with trauma-informed care. And these next two are more to do with eco-social work. So thank you very much for listening.